Today, I will be discussing eating disorders and how they relate to the dimensions of wellness. Our outline today is to list and define each of the commonly recognized eating disorders, go over some important statistics and considerations with eating disorders, go over the proper language used with eating disorders, how eating disorders are related to the dimensions of wellness, and what a dietitian's role is in eating disorder treatment. Our learning objectives are to recognize and understand the major eating disorders and possible underlying causes, familiarize ourselves with the diagnostic criteria for eating disorders, understand the proper language used during eating disorder treatment, and understand how areas of wellness are affected by eating disorders. So, what are eating disorders? Eating disorders are behavioral conditions characterized by severe and persistent disturbance in eating behaviors and associated distressing thoughts and emotions. The commonly recognized eating disorders are anorexia nervosa, bulimia nervosa, binge eating disorder, avoidant restrictive food intake disorder, also abbreviated as ARFID, pica, and rumination disorder. I will go through how we define each eating disorder, and on the slides you will see the diagnostic criteria taken directly from the DSM-5. I will not read them word for word, but I included them because I think it's important to familiarize ourselves with these criteria. Feel free to skim over them as I describe each eating disorder. The first is anorexia nervosa. Anorexia nervosa is an eating disorder characterized by weight loss or lack of appropriate weight gain in growing children, difficulties maintaining an appropriate body weight for height, age, and stature, and in many individuals, distorted body image. People with anorexia generally restrict the number of calories and the types of food that they eat. Some people with the disorder also exercise compulsively, purge via vomiting and laxatives, and/or binge eat. Bulimia nervosa is an eating disorder characterized by a cycle of binging and compensatory behaviors, such as self-induced vomiting, designed to undo or compensate for the effects of binge eating. An episode of binge eating is characterized by both of the following: eating in a discrete period of time, such as within a 2-hour period, an amount of food that is definitely larger than most people would eat during a similar period of time under similar circumstances, and a sense of lack of control over eating during the episode, such as a feeling that one cannot stop eating or control what or how much one is eating. A misconception about bulimia is that a person will be clearly either under or overweight, but a large percentage of those with bulimia are of a normal weight or just slightly overweight. Binge eating disorder, abbreviated BED, is an eating disorder characterized by recurrent episodes of eating large quantities of food, often very quickly and to the point of discomfort, a feeling of a loss of control during the binge, experiencing shame, distress, or guilt afterwards, and not regularly using unhealthy compensatory measures, such as purging, to counter the binge eating. This is the most common eating disorder in the United States. Avoidant restrictive food intake disorder, abbreviated ARFID, is also known as extreme picky eating. It is an eating disorder characterized by highly selective eating habits, disturbed feeding patterns, or both. It often results in significant nutrition and energy deficiencies, and for children, failure to gain weight. Common eating and feeding challenges for an individual with ARFID include difficulty digesting food, avoidance of specific types of food textures, colors, and smells, eating at an abnormally slow pace, or having general lack of appetite. Pica is an eating disorder that involves eating items that are not typically thought of as food and that do not contain significant nutritional value, such as hair, dirt, paint chips, and other dangerous substances. Rumination disorder involves irregular regurgitation of food that occurs for at least 1 month. Regurgitated food may be re-chewed, re-swallowed, or spit out. Typically, when someone regurgitates their food, they do not appear to be making an effort, nor do they appear to be stressed, upset, or disgusted. Now that we can differentiate among the major eating disorders, there are a few statistics and eating disorder facts I would like to share. There are several common misconceptions that come along with eating disorder diagnoses, as well as unique circumstances we must remember when we encounter patients or clients with eating disorders. We have to remember that there is no handbook or textbook definition about who may be affected by an eating disorder and what a quote unquote typical eating disorder looks like. The experience of having an eating disorder looks different for everyone. Eating disorders affect around 9% of the world population, which may seem to some like a small number, but in the US equates to just under 30 million individuals. Eating disorders can affect those of any age group, gender identity, ethnic group, or any other group. Eating disorders do not have a certain look when it comes to who they affect. Only 6% of those diagnosed with an eating disorder are actually classified as underweight. An obvious, and I say the word obvious carefully, sign of an eating disorder is extreme thinness. This is not untrue, but we need to keep in mind that a young adult or athlete, for example, that fits the criteria of a normal BMI and may appear to be healthy may actually be significantly struggling with an eating disorder and experiencing dangerous symptoms. Because we don't know what an eating disorder looks like, we must refrain from making any assumptions or passing any sort of judgment about our patients and clients, as they may be struggling with disordered eating patterns behind the scenes. Eating disorders not only mainly affect women, but they also affect men. Approximately 1 in 3 people diagnosed with an eating disorder will be male. Subclinical eating disordered behaviors, including binge eating, purging, laxative abuse, and fasting for weight loss, are nearly as common among men as they are for women. Eating disorders also disproportionately impact members of the LGBTQ+ community. There is not enough research to have definitive statistics on what we know about this population as it relates to eating disorders, but LGBTQ+ identified individuals experience some unique stressors that may contribute to the development of an eating disorder. Black and Indigenous people of color are also less likely to be asked about eating disordered habits by doctors and are less likely to be diagnosed with or even receive treatment for eating disorders. With this in mind, we must be aware that minority groups are at a disadvantage and are disproportionately affected by eating disorders. We must be allies for these groups. The way we talk about eating disorders matters as we learn and grow as future dietitians. Using proper language around eating disorders is the first step in creating a safe environment to facilitate conversations between clinicians and patients before even starting treatment. There is a push to use person-first language when speaking about individuals with disabilities and mental health disorders, which includes eating disorders. As an example, in the phrase, "she is an anorexic," there is an implication that having anorexia is what defines this person, and is not a very empathetic thing to say. This puts the disorder before the person. In the second phrase, "she is a person suffering from anorexia," this creates a separation between the person and the disorder. Of course, when possible, checking in with patients and asking about their preferences regarding language around eating disorders is always the way to go. As a short activity, there are 4 phrases on the screen that are not so great when speaking to and about those with eating disorders. I will read each phrase, and in your head, or on paper if you prefer, try to think about how we can flip these phrases to be person first and non-judgmental. I will give around a minute or 2 to do this. Pause if needed. 1. I had an anorexic patient the other day that looked super skinny. 2. Why didn't you eat lunch like I told you to in our treatment plan? 3. She ate a whole package of Oreos the other day. That's so gross. 4. I think you're bulimic and should see a therapist. Now that you've thought about it, here are ways that I thought these phrases could be changed. Of course, there are no right or wrong answers. Number one, I saw a patient suffering from anorexia and I have concerns about their body weight. 2. I'm concerned that you skip lunch. Tell me what we can do that would make eating lunch easier for you. 3. She lost some control when eating a snack the other day. Hopefully, she will talk to me or a professional about it so that it doesn't happen in the future. 4. I'm concerned that you may be suffering from bulimia. If you're open, I would like to help you find a licensed professional to help you through that. As a summary, here are a few things to do and avoid. We should avoid making assumptions, commenting on body size, having a judgmental tone and judgmental language, and telling rather than asking. Things we should do are offer support when appropriate, be body neutral, affirm positive changes that our patients and clients have made that are not related to how their body looks, and asking rather than telling. Eating disorders affect several areas of wellness that we have previously discussed. The first area I'd like to discuss is the mental emotional dimension. First and foremost, we just discussed how important using proper language is. Using proper and respectful language helps patients with eating disorders feel safe, validated, and heard, facilitating the mental emotional dimension of overall wellness. Eating disorders, again, are considered mental illnesses and often come with very strong or distressing emotions associated with trauma. There's often a co-occurrence with other psychiatric disorders like mood disorders, anxiety, obsessive-compulsive disorders, as well as substance abuse. Understanding the mental and emotional aspects of eating disorders is arguably the most important part of eating disorder treatment. You can't focus on bringing back physical health if the root cause of the disorder is not addressed first and foremost. Helping patients through their mental and emotional roadblocks and helping them understand the seriousness of their disease is the first step in helping them regain their health. When we think about eating disorders, they're often associated with physical problems like weight loss, malnutrition, etc., which are a big part of the characteristics of eating disorders. There are potential risks to virtually every body system. This is including but not limited to cardiovascular, gastrointestinal, neurological, and endocrine. I'll give you just a second to glance at what these symptoms can include. An eating disorder diagnosis can impact and impair not only mental, emotional, and physical wellness, but the other dimensions of wellness as well. Environment plays a significant role in eating disorder development. Outside pressures, such as body standards in media and pop culture, diet culture, and even comments about body size from friends, family, and peers, all have detrimental effects on how individuals view themselves and are all risk factors for eating disorder development. The quote that's on the slide reads, "The best known environmental contributor to the development of eating disorders is the sociocultural idealization of thinness." We see this everywhere, on TV, magazines, and most importantly, social media. Eating disorders have a significant social impact as well. Those diagnosed with eating disorders report having smaller inner circles and often become distant from people in their inner circle. Social gatherings become difficult as food is involved in most social gatherings. All of these factors play a role in a person with an eating disorder's quality of life. So, where does the role of a dietitian come in? In a client and dietitian relationship, the dietitian supports the client's need for behavior change. These changes are meant to challenge distorted and irrational thinking about the relationship between food and weight and to explore feelings related to hunger and fullness. It's imperative that the client engages in nutritional counseling without any fear of being judged. A dietitian will conduct a thorough assessment based on lab results, medical history, anthropometric measurements, and lifestyle factors such as exercise regimen and general eating patterns. A nutrition assessment reveals current dietary intake, beliefs about food and weight, if they use supplements, and down to who cooks, buys, or prepares meals. It's encouraged for a client to express their emotions, feelings, and fears around food and weight and the goals they wish to accomplish. The dietitian is then assigned the task of exploring, challenging, and helping the client replace the mental distortions that cause and perpetuate specific food and weight-related behaviors. This is to allow the client to know that the overall goal is to return food and meals to their normal place as a source of fuel. Dietitians are crucial team members for the treatment of eating disorders. Dietitians work alongside other interdisciplinary team members to help eating disorder patients access the physical and mental dimension of wellness. For a final activity, I would like you all to hop online to any form of social media and follow, browse, or subscribe to a person who has been willing to document their difficult journey of being diagnosed with an eating disorder. Personal accounts are a great way to help us understand what an individual with eating disorder goes through. This can help us be more understanding of our patients and clients and help us be more competent. Thank you for your time.